So Joost, yeah, Joost is going to speak to this really exciting natural history study that's now um, getting close to publication on KS. And so excited to hear all about this. And so
Yes.
go ahead, Joost. If you can introduce yourself and then
I will.
yeah,
Well, first of all, thank you very much, Eric. Thank you very much, Jeff. Impressive all the work that you've been doing the last couple of years. You've been immensely putting a lot of effort into doing research into the community, and I think from the Netherlands, a great thank you from that for that as well. I will try to share my slides. Let's see if I can do that. Just one moment. And now, it's always a bit of a hassle, but I think we're managing.
yeah, I see your screen now. I don't see your slides yet. Oh, there we go. I see your slides.
Do you see my notes or my slides?
I see your slides.
You see my slides. Okay. Yeah. Okay. Yes. So, first of all, again, a great thank you for giving me also the opportunity here to speak for the Radboud University Medical Center. My name is Joost Kummeling. I'm a medical doctor situated in the Netherlands. And since 2018, I've been involved in the project of Kleefstra. And I've been working a lot on the natural history study that we've performed here, and also in collaboration with Boston Children's Hospital. And it was a couple of years ago. Actually, flew to Boston. It was a lovely experience meeting all the dedicated researchers over there, and had a lovely time with them. And also I learned a lot from them. And today I will be hoping you to give some insights and some future perspectives on what we did with a natural history study. As a main focus, I used to work full-time as a researcher in the Radboud University Medical Center. Now most of my days I spent here at Dichterbij, which is a healthcare provider for people with intellectual disabilities. And the interesting thing is, in the Netherlands we actually have a special specialization that doctors can follow. So they have a 3-year course, or a 3-year just a whole study on how to become a specialized doctor in ID. And this whole experience of me with Kleefstra syndrome doing research has inspired me to also to start this specialization quite soon. So hopefully in 3 years I will be a fully qualified specialist. So at this moment I'm just a basic doctor here in the Netherlands. I will be giving this is the overview of what I will be telling. So I will start with a general introduction, then I'll move on to the research that I've been doing in collaboration with lots of partners. I will be talking about developmental regression, which can be quite a big part in individuals with Kleefstra syndrome. Then we talk more about the natural history of things. We will delve into the effectiveness of treatment with olanzapine, and then we move on to the general discussion and some of the future perspectives. So, well, I'd like to begin with more of a broad view on things. As well, if we look at equality of health, well, we see that there's still quite a health gap, sort of a difference in the quality of healthcare and health itself between people with intellectual disabilities and people without. And people with intellectual disabilities often have health problems that are not noticed, or diagnoses that might be missed or not properly treated. And at the same time, these people are more often likely to have multiple diseases. They have to visit multiple doctors, and they have to take medication, and sometimes quite a lot. And in addition to this, if there's a delay in diagnosing all these problems, this can lead to a worse prognosis of those problems. So this we all have to take into account when treating somebody with an intellectual disability, and all this comes together with Kleefstra syndrome, because also caring for people caring for people with an intellectual disability can be even more difficult when there's a genetic syndrome involved, such is the case of Kleefstra syndrome. And these genetic conditions can affect how a person communicates and thinks, but they also can cause other problems like congenital heart defects. Contributing to this, and this is what Tjitske Kleefstra mentioned, there's a knowledge gap, and this is what the guideline efforts have been trying to work on. It's a rare disease. People with Kleefstra syndrome are scattered all around the globe, and we see today there's with this summit that there are luckily a lot of people phoning in from all kinds of places from the world. But in this case, people are scattered around the globe. Knowledge is also scattered around the globe. So, and there's also a contributing factor to this, that knowledge is also divided into all kinds of different disciplines. So we have all sorts of knowledge islands scattered around the globe, which makes doing research quite hard. We need to get more knowledge on Kleefstra syndrome. That's the main goal. But how do we do this? We have to in some way get everything we know together and then build on that. So one of the things that we wanted to do for this for my studies is to build a framework on how to perform studies on a multi-disciplinary and an interdimensional scale. This all to improve care and to reduce this health gap that we mentioned, and also this knowledge gap. And when we think about patients with intellectual disabilities, well, there are of course multiple disciplines involved, and for my presentation I will be talking mainly about genetics, psychiatry, biology, and psychology. And bringing these disciplines, these people that work in these areas of expertise together is one of the main goals for me, but also important for the patient. And in fact, in a way, we're also already doing this right here at the Radboud UMC, where we have, and you will hear a lot more about this later this day and tomorrow, where we have smart people working on a mouse model with Kleefstra syndrome, flies with Kleefstra syndrome, and they're researching Kleefstra syndrome in neurons. But me, I'm just a simple doctor. I work with people, so that's the human part I will be focusing on. Specifically, psychiatry in Kleefstra syndrome. This is the main part of my studies. It's basically an extension of the work of Carlijn Vermeulen, who is a children's and youth psychiatrist here in the Netherlands. A couple of years ago, she worked on her thesis, where she studied psychiatry and neurocognition in genetic developmental disorders, and more specifically, Kleefstra syndrome. And I just wanted to show you this bar on the, like, you can see my pointer, you can, yeah, I think. Yeah, I have very tiny screens to work with, so sorry for sorry for that. But if you look at this this graph over here, you see that Kleefstra syndrome is she compared it to other similar genetic rare syndromes, and what she saw is that if you combine all the psychiatric comorbidities, all the psychiatric problems that might occur, that patients of people with Kleefstra syndrome might have a higher burden of psychiatric illnesses. And for the main part of this presentation, I will be focusing on this brown bit and this purple bit, which correspond with regression and psychotic disorders. So, is this a, I don't know, next one. So, developmental regression. Well, what is developmental regression? It's quite a medical term, and it means loss of skills basically, and it often occurs with behavioral changes like aggression, like a loss of interest or social avoidance, and psychotic symptoms. And important to notice here is that psychotic symptoms often present differently than most physicians, most psychiatrists are used to, because well, people with Kleefstra syndrome or other people with intellectual disabilities often show different signs of psychosis. Most psychiatrists are used to people having like delusions or hallucinations, like a patient comes to them and says, "Well, doctor, I'm being followed by somebody," or "I have the idea that the man on the television is talking to me." But this often is not the case in Kleefstra syndrome, which is because it is possible that the person with Kleefstra syndrome doesn't have the tools to communicate in that way. So often we don't, psychiatrists don't hear delusions, hallucinations, but more like things like disorientation or just changes in behavior, broadly speaking, and which is important to know. In addition to this, a loss of sleep can be seen as a precursor. It might sometimes it is, sometimes it isn't, for this episode of developmental regression, which may happen in Kleefstra syndrome. And this is the paper that that Carlijn van Meulen wrote a couple of years ago, where she stated that a sleep disturbance can be a precursor of the severe loss of skills in the Kleefstra syndrome, and this whole phenomenon suggests a need for a firm and rapid pharmacological treatment. And she, in fact, treated many instances where she treated with an antipsychotic drug, which is called olanzapine. Let's see. And now my screen has some issues. Okay, yes. Now, some more information on regressive symptoms. They often arrive during puberty, after some sort of observed stressor, and this might be the death of a family member, somatic illness, or moving to a new home or school. All these things are, of course, very stressful to people who do not have Kleefstra syndrome. So imagine if you have Kleefstra syndrome and you have, it can be quite hard to deal with this stress that might occur during your lifetime. And puberty is often a period in everybody's life where that can be quite stressful. Originally, we thought that around 30 to 50% of people with Kleefstra syndrome will develop some form of regressive symptoms during their lifetime. But this number seems to be a bit dated, but I will go into that a bit later. To give you one more example of what developmental regression is, let's say this individual during the lifetime has acquired a couple of milestones. They've learned to write, learned to tie their shoelaces, learned to make friends or ride a bike, and also communicate with words. After some sort of stressor, like I told you before, it might be that they lose some of those functions, and it might be that after a while, some of these things, like verbal communications, comes back in one way or another, but in practice, it's rarely the case that they fully come back to their original level of functioning, which is quite impactful, as you might think. And that's why we try to set out a broader study for this. So this diagnosis of regressive symptoms is often missed because it's hard to recognize. It's hard to treat as well because from a couple of years back we didn't know how to do this, and well that's why we set up this study. And often might be a bit overlooked, but of course we're together with today with the Kleefstra syndrome community, and the KMT2C community might be joining as well. But regressive symptoms are not restricted to the Kleefstra syndrome. There are many other syndromes that are associated with a form of regression one way or another, just like Phelan-McDermid, which Tjitske Kleefstra mentioned in the last presentation on the guidelines. So there are a couple of parallels there to find as well between Kleefstra syndrome and Phelan-McDermid, but also MBD5 mutations may also lead to some sort of regressive problems. And I've also published a scoping review on many different syndromes that might be associated with developmental regression. I won't go into that much, but regarding this, the Kleefstra syndrome community is not alone. So we have to bundle the information that we have. For the natural history study, we set out a couple of objectives, what we wanted to learn, what we wanted to do. And as our first objective, we wanted, of course, to fully understand, or at least to our best extent, understand the natural history of Kleefstra syndrome, and to also understand the developmental regression that might occur. And as a second objective, as Carlijn Vermeulen provided the stepping stone for this, we wanted to investigate the effectiveness of olanzapine on an individual level, since this can be developmental regression can be very impactful. And we ask ourselves the question: is there any benefit from an early detection of regression and therefore and subsequent treatment with olanzapine? We set out to establish a test battery, which is also quite a challenge, because how do you test people with an intellectual disability? Most standardized tests aren't really configured for people with intellectual disability, so it was quite a search to get the right questionnaires and neuropsych tests. But in the end, we managed to pull through, and we established quite an interesting, quite a comprehensive test battery as well. And questionnaire-wise, we wanted to measure things like communication skills, daily living skills, but also social skills. And these three domains, I have to say, together we call adaptive functioning. And the adaptive functioning is an interesting concept, and I will talk a lot about this term in this presentation. So for just to be clear, I want to show a couple of examples of adaptive functioning, about some couple of examples about what things do we have to ask in the questionnaire. Communication wise, we ask, like, does the person that we talk about know the meaning of at least 10 words, or can the person indicate a preference if allowed to choose between things? That's all in the domain of communication. Regarding daily living skills, we ask if the person is able to eat with a spoon, is the person able to make their own bed. And regarding social skills, we ask questions like, does the person express two or more recognizable emotions such as happiness, sadness, fear or displeasure, and can the person keep a secret for at least one day? And these are all examples of questions we ask when we do this questionnaire, and this all contributes to the to adaptive functioning if you add it all up together. And in addition to this, adaptive functioning is the main outcome of our study, but in addition to this, we also wanted to measure via questionnaires how our person sleeps, because well, of course, we've seen that sleep disruption can bring problems. We also wanted to look at mood disorders if they were present, and look into any psychiatric or psychotic problems. Regarding neuropsych tests, we wanted to objectify traits of autism spectrum disorder, and we wanted to map the capacities of learning and memory in Kleefstra syndrome, and also visual motor integration we wanted to look at. And the visual motor integration is sort of a collaboration between different parts of the brain that sort of look at something and coordinating movement afterwards. And in a broad case, with this test, we wanted people to copy a drawing, like a very simple drawing, like a circle or a line, those kind of things. Tjitske Kleefstra talked about working digitally, which is very important, but most of these questionnaires, when I started, were in paper form. So we worked with these. This is a questionnaire. There's one digital one, which is the CanTab, which is right here at the top, which is a tablet test. But everything else was mainly on paper, and for every person involved, we filled out all these papers, and we all put them in this file cabinet. And you see numbers 1 till 40 right here, because in the Dutch part we included 40, but I will show you something more about the Boston part as well. And afterwards, don't stress everything. This was uploaded online, so everything is digitally available now as well. Thankfully, and we can work through the data much easier. For this study, we've designed we've set up a sequential design, which means that after at inclusion, we did the tests of the questionnaires and the neuropsych tests, and after year 1, we did the same. After year 2, 3, 4, we really repeated all those measurements. And in the case of when we saw that there was the start of a psychotic problem, we looked at if the treatment with olanzapine was an option in this, and that we did this mainly by looking into the data and seeing if there were any differences in the questionnaires, if there was a decline in adaptive functioning, maybe in combination with clinical, like behavioral problems as well. And if that was the case, if we could clinically establish a period of developmental regression or a psychotic disorder, we worked in close collaboration with their own treating doctor to start off treatment with olanzapine, which is the olanzapine part is mainly only on the Dutch side. The American side officially didn't have this specific construction. And in the case when there was a developmental regression, we also doubled up on the measurements, where we did it twice per year instead of once per year, just to get more information on a specific period in time. And we also added a retrospective analysis via questionnaires. We asked the caregivers or families or caregivers in a sense, their what they knew about the person in question, if what their level of functioning was before we included them. So just to get a really broad perspective on what was happening and what was this person's level of functioning beforehand. This is a map of the Netherlands. This is what Joost Kleefstra also told, I think an hour ago, about me, where for this study we included people, children from the age 12 until indefinite, so from 12 years up, where we because we wanted to look mainly at the developmental regression periods, and of course, as I mentioned earlier, that developmental regression often occurs usually around puberty. So it doesn't make sense to include people younger than 12. And here in the Netherlands, I drove all around to visit patients in their own home or in their own healthcare facility where they were. And we set up this collaboration with Boston Children's Hospital, and everybody in the United States was able to fly to Boston. And now I'm going to show you some of the results. So this is the total cohort we mentioned to get together. Here in total, we found 53 participants, which is quite a huge number, especially if you consider that the Netherlands is quite a relatively small country, and at the time we didn't have that many people with Kleefstra syndrome on our radar. That number has grown, luckily, for us. So we can gather more knowledge. And in the end, around 16 people had olanzapine treatment at some point during the study. And this is sort of a ratio of males and females in the cohort. Around the majority was female, 34 participants were female and 19 were male. And a majority of the participants had a deletion, had a specific pathogenic variant in the EHMT1 gene. The other third, like 16 people, had the deletion of the 9q34.3 region. And as I told you, around 16 had the olanzapine treatment in total. Some interesting things that we find if we look at the data comparing adaptive functioning, sort of the three domains of communication, daily living skills, and social skills, when comparing the Netherlands to the United States, is when we look at the data, we see that the individuals in the Netherlands have a lower level of adaptive functioning than the individuals with in the United States, which is remarkable at first glance. But then if you think about it, there might be some selection bias happening here, because in the Netherlands, the patients were visited in their own home, in their own care facility, so which is in most cases quite easy to do. In the United States, it's can be a more difficult question, because maybe they had to visit. Of course, everybody had to visit the study site in Boston, and maybe not everybody with Kleefstra syndrome is able to go cross country by plane, by car, drive a lot of kilometers or miles just to visit a hospital. So it might be so that people with a higher level of functioning are included in the United States leg of this research. And of course, we can see here at the bottom of the screen, there's the numbers that contribute to this data. So sometimes the numbers differ a bit, but it all depends on the data that we had available at the time of when I made this graph. And if you look at different, if you look at the ages of the participants, you see that males and females around all around the same age, around from age 15 or older, with a sort of a mean around 22, 25 years old. So this is comparable, males and females. But if you look at the level of adaptive functioning, which is quite interesting, you see that the females, the ladies, have, generally speaking, a higher level of adaptive functioning than the males. And this is quite interesting because, well, we do not really know how this happens, what's the etiology, the basis of this. It might be that there's some sort of female protective effect in this case, that for some reason, if females have a pathogenic variant in the HMT1 gene, that there's some reason that they get a milder phenotype. We do not know exactly yet how it works. And now the most, I would say, the most visually speaking, the most horrific slide in my presentation, which is this one, which is all lots of colored lines and dots. It looks well. I've tried to make this look better, but it was not possible for me. Anyway, I will try to guide you through this. I will pull this apart. What you see here is on the x-axis the age of all the participants, and on the y-axis the adaptive functioning level. And this is also with the Vineland Z, you can make a correspondation with the level of functioning and how do you say it? You can put a year on it, so a developmental age, so to speak. So this bottom line here corresponds with a developmental age of around 11 months, and this top line here corresponds with the developmental age of 12 years or older. So as you can see, this part, this broad part, there's a big spread of levels of adaptive functioning, big spread of developmental ages. And let me move on to this interesting part here, to the more older participants of our group, and which is, if you zoom in, we see this, and we see that I think almost everybody that we followed for multiple years, or these are all retrospective analysis, I have to say. So that's why these lines are dotted, where we checked the developmental age of the patients around this area, and we also asked their family members or sisters or brothers, parents, if they were still alive, how they functioned before, and we see that they functioned around this area. So broadly speaking, on a higher level. And we wanted to, this is all part of our first objective, to understand the natural history of developmental regression. But we see this and we think, we scratch our head a bit, but because we see in a way that I think everybody in a way, one way or another, has some form of decline of the level of adaptive functioning. And we think, why? Why is this happening? Is this sort of a natural decline that happens to all of us as we get older? Is this a lack of adequate support in their direct environments? If I sit on the couch all day for 30 years, well, I will lose my social skills as well. So I need to be able to train myself to keep just keep on swimming in a way, or is this developmental regression or something else? And to properly establish that what we see here is a developmental regression, we really have to take into account their historic reports. What was happening at the time? Was there some sort of stressor at this time? And did we see behavioral changes at the time? Was this a rapid decline or just a slow decline over time? We actually do not know yet, because historical reports, if we look into those historical reports from the 80s or even 70s, they lack details. It's rarely even that we find data on what happened at that period. So in fact, the conclusion, the sort of frustrating conclusion as well, is that more information is needed in this case. But the bottom line is, we see that the group of older participants have had some sort of decline in adaptive functioning during their lifetime. So the 30 to 50% that I mentioned earlier, so the developmental regression might be higher, but we do not know for sure at this moment in time. Moving on to the olanzapine study, which is to investigate the effectiveness of olanzapine, we collaborated with Kit Roes, which is has a lovely picture right here. He was a professor in research methodology, and he suggested, well, to measure effectiveness of olanzapine, you can check the points that you have before start treatment of olanzapine with the points of adaptive functioning after starting with olanzapine. You can draw lines between those. And what you see here is just one individual where we did that. So we have the age again on the y-axis, and again the adaptive functioning scores on the y-axis. And this person here, you can see at a certain point in time, had a very sharp decline in adaptive functioning. Was quite high up in the beginning, and then very fast in almost a year time, lost a lot of skills. So there's a very sharp decline over here. Then afterwards, she started treatment with olanzapine, and then very quickly she also sort of recovered to a certain extent. And we see that after a certain point in time, you see some fluctuations over time, which we're not sure yet if there are is it still a sort of a gradual decline, or if it's a sort of a still a if treatment is still effective. We're not really sure, or if this is a normal fluctuation of adaptive functioning within the Kleefstra syndrome group. But what we can see is that olanzapine treatment for this person really helped to bring back the level of adaptive functioning to not specifically previous levels, but to a higher level than significantly higher level. And we see that we have to look at those lines, those two slopes. If we compare those slopes, it's a very increase of the slope, so it returns back almost to normal. We had this approach with this person, but we checked also other individuals who have had olanzapine treatment with multiple measurements before and multiple measurements after the start of treatment. And in the end, there were I have to say 7 individuals who received olanzapine treatment at some point, where 6 of them improved in one way or another. So if you look at this person, well, before olanzapine treatment, there was a gradual decline of functioning. When they started off with olanzapine treatment, there was an increase of adaptive functioning, and even more, it even ended up higher than before, which is quite interesting as well. But I think the adaptive functioning before was a bit higher as well. So you do not increase somebody's adaptive functioning just by starting olanzapine treatment. I have to say that there was one person who did not improve, and we don't know. As of yet, we do not really know why this person didn't improve. It's possible that this person already functioned on a quite low level of adaptive functioning, and it might be that this is sort of an error margin in a way, and it was also very relatively older patients, around 30, 40s. It might be that in older patients, when there was already some sort of a decline, we do not have the tools yet to properly treat them. But at least the bottom line here is that at least 6 of them, of the 7, are improving. Also, there's this patient number 19, which received clozapine treatment, which is also a sort of a medication in the same realm of olanzapine, only it might have severe side effects, like the agranulocytosis, which means that your white blood cells stop working. We see that this medication can be quite potent in a lot of patients with psychotic problems. But we started this patient was they started with a clozapine treatment. After olanzapine treatment didn't seem to have enough effect on the delusions specific that this person had. But anyway, the bottom line is that we have an early positive effect of treatment, and at least we seem to influence the course of this developmental regression via treatment with olanzapine. These results are about to be published, so let's see that let's hope that we bring this into the broader world. Future perspectives. Well, when doing all this research, you have to think about the future as well. What do we want from now? We've made it so far. What's our next goal? From my perspective, of course, I've been focusing on the psychiatric part of Kleefstra syndrome, but I also want to say just internationally, and that's why I'm also here talking to you about this. We want to strengthen international collaboration and to have a further standardized testing for people with Kleefstra syndrome, because, well, if we know how to test them, probably we can objectify their problems more easily, and we can move on to more treatments as well. For me, well, I also wanted to look into long-term effects of olanzapine, and also in the case of when olanzapine doesn't have the effectiveness that we would like to have, we want to explore other options. What's our plan B in that case for developmental regression? And it's also important to investigate the factors behind the differences in levels of adaptive functioning between the genders that I mentioned, as the females for some reason have a higher level of functioning. And also important to know that it's good to explore which other entities are associated with developmental regression. I mentioned the scoping review, where I get a more in-depth approach to all the other syndromes there might be, but I think we've just hit the top of the iceberg regarding that. All this effort to join, to make all these disciplines join together and improve the care and reduce the health gap for understanding developmental regression, and let's hope we can move towards personalized therapies very soon. This is the end of my presentation. I would like to thank all these people and many more, of course. The slide gets more crowded every time I do this presentation, because there are many people involved in this collaboration between all kinds of institutes, all kinds of people with all kinds of own expertises, and it's lovely working with each and every one of them. It's lovely speaking to you, with of course permission of Eric and Jeff. And I would like to thank you for sitting through all this and having this immense impact on the Kleefstra syndrome community. And if you have any questions, now is the time to let me know. You can email me at my work email. I'm not really the primary focus is on the this is my work email. If you mail me, I might not respond immediately, because patient care is my number one priority. But if I see time in between patients, I might actually write you back, I hope. So this was my presentation.
Thanks, Joost. I think really amazing to see this work starting to come out, and I think also great reminder in your second to last slide about how many people it took to do this work, to all the clinicians plus all the patients, and it's just a huge, it's an amazing project to start to see come to fruition, and I'm really excited about. the potential impacts, this better understanding we're getting about regression. And one of the questions we had in the chat while you were talking was about how to define regression. So the questioner said that she has a 5-year-old who was diagnosed in the womb. So very, very new type of situation that we're going to start seeing more and more. And he actually regressed at about a year. He had open heart surgery and then had regression after that. And so she was asking about kind of how do we define that regression is always going to be at this 12 and up range. And how do we define that type of regression versus maybe other regression, I think was the question that maybe can be seen in Kleefstra syndrome. So do you want to comment on that?
Yeah, of course. It's a good point. So what the main focus was, of course, doing research on the developmental regression that might occur during puberty. But the main part is that we see that at around that point in time, we see a lot of stress happening. We see a lot of somatic illnesses as well arising, and which may lead to developmental regression. In this case, is because it seems that people with Kleefstra syndrome can be quite vulnerable to this. And as this person mentioned, it can happen at a younger age as well. It is not an exception, but it happens, and that's why we try to define developmental regression not on the age at which it might occur, but mainly on the period which it takes. So if it might be this period has to have a duration of at least a couple of weeks or months before you can speak about the developmental regression. It might happen to me that if one day I don't have any sleep, the next day I will be just a bit in a bad mood, or a bit more irritable than normally, or I do not want to talk to anybody, or just want to sit at home. Doesn't mean I'm regressing, and I think age in that case isn't really the most important factor. I think mainly it's the duration and that happens, and also, of course, in which domains it happens.
Great. Yeah, I had a question for you, which is, what do we know about regression, and when can it happen without psychosis? Right, because I think mostly you were focusing on the cases of psychosis, loss of sleep, and then that leads to regression. Did you have any comments on kind of the different types of regression we might see in KS?
That's very interesting, because at some point we in a way we are still lacking information regarding that, and we see mainly during puberty that it can be some sort of developmental regression, and it really depends on the individual itself if there are any symptoms of psychosis, yes or no. It might be just a decline of some form, some skills that one. It might happen just when somebody moves from their home to sort of more of a healthcare facility. That there are other healthcare providers there that do other things, that have other approaches to caring for those individuals, and maybe they also start to work more, just even learn more skills. That also happens, but we see, especially during puberty, quite of a, relatively speaking, we can see a sharp decline in a very small amount of time, which may or may not be accompanied with psychotic symptoms. And afterwards, we see also but this is where evidence is lacking at the moment. Also around if some, at least the females are around the years around age of 40 or something, they might also, during menopause, if they started to enter menopause, they might also with a sort of a hormonal dysregulation, might also have some sort of period of regression. And it also seems to sort of the main ground is stress, and this might be somatic, might be hormonal, but it also but this can happen at any point in time at some point somebody's lives, and you cannot really predict how it will happen, or in what way it will happen. But if there are any symptoms, if there are any changes in behavior, if you see that your loved one is behaving differently, then it's might be time to think about, well, it might be that this is happening. Yeah.
Yeah, I think it's great, really great point. And I think the takeaway is if you're seeing changes in your loved one where they seem to be losing skills, go see your doctor and say,
Yes,
this might be regression. Let's look into this. I think that's maybe the action for all families.
it's the call to action.
Don't
Yes.
wait. um, so there's another question from the chat about does regression sometimes show up as significant weight loss? Have you seen anything like that, or was that tracked in the study?
We didn't. We tracked weight at for certain individuals, but it was mainly because weight can be also a contributing. It can be a sort of side effect from treatment with olanzapine.
Yeah.
So we
Okay.
really wanted to check if a person treating was treated with olanzapine had a weight gain, which can be quite debilitating as well, and it can also have all other kinds of health effects. We didn't find specifically that a weight loss, just a weight loss with no other things, can be a trigger for developmental regression. But that's not to say that there isn't, because there might be some sort of somatic underlying illness, which is also important just to check if in what way where does this weight loss come from? Is this a weight loss where the person stopped eating because of the stress it gave them, because of the behavioral changes themselves? What is sort of a chicken egg situation? What happens before? It might be that the regression has an impact on weight. It might be that weight has an impact on regression in this case. But
yeah, and I think it's a really good call out. You can see, I think for the people who are listening to this discussion, you can see how complicated these issues are and why you have to do these kinds of careful studies, because it allows you to start to disentangle some of these questions that we see clinically, right? That clinicians have seen for a long time that KS puts you at risk for regression, but really understanding in a rigorous way the types of patterns, when it can happen, why it can happen, is really, really important. And I think it's also worthwhile calling out the new natural history study that's going to happen at Boston Children's, which is going to be on younger children. It may be possible we'll see. In fact, there are a couple cases in that cohort. Hopefully it won't happen, but we might see that there's regression in younger kids as well. And that'll get captured in that natural history study. And then we'll learn something new about, oh yes, it can happen to younger kids. And maybe we'll have some idea of what were the stressors or what were the conditions that triggered it.
yeah.
And then each of these studies, we get a stronger sense of what we can expect and what we need to look for and what we need to address. So yeah.
We just have to bring to attention that these problems, any kinds of stressors can start off this period.
Yeah, I think it's really important. And we've had a few questions about nutrition and nutrition for kids in general with KS, and then also, did you analyze nutrition, chronic inflammation, diets as a potential factor, and is that something that we should be thinking about?
Well, I did not. Me specifically did not looked into nutrition at this in this case, so I'm afraid not. I think Ariane Bouwman, who was mentioned by Tjitske Kleefstra a couple of in her presentation, who worked on the guideline, has also worked on nutrition and Kleefstra syndrome, but I'm not really sure what exactly her findings are in that case. But you can look up Ariane Bouwman and probably find interesting publications on her site on this subject.
Great. And I'm looking at another question to pass through to you.
Just keep them coming, Eric.
Yeah, I just have to read them first. So I had the question came through. Did you I think the answer is yes, but when you did this study, did you observe emotional problems or challenges in KS patients, for example, outbursts, and how did that change with age during the study? Those, if there were emotional outbursts or events like that, is that something that was tracked, and did you learn anything in the study about that?
Yeah, emotional outbursts are actually it can be quite frequent, which emotional outbursts are interesting to place because, of course, I didn't mention that much during my presentation, but many individuals with Kleefstra syndrome might have something like autism spectrum disorder traits, and which might lead to emotional outbursts, especially if a person is used to a certain routine in their daily life, and if something happens, something changes, where they originally they thought they would be doing like going swimming, or then somebody gets ill and they have to stay at home, something like that. And it's this sort of this if you just break out of that routine that they have, it might lead to emotional outbursts. And of course, this can be quite a factor as well with Kleefstra syndrome. So we took that into account as well.
Okay. And then I think the question came up, it's a really good question, is in this cohort, what was the final percentage of patients that underwent regression versus patients that did not undergo regression?
I
Did you
think
end up with a final number?
well, it's quite hard to do just to have a hard number on this, because I mentioned, well, the older group, it's very difficult to establish developmental regression if there wasn't a clinician present at the time who wrote everything down in detail. So from that older group, it's very difficult just to say what happened. And I think actually from this cohort, for where we definitely established this developmental regression, we can say that from around the 50 patients, we have around 10, 15 who actually declined during the period that we saw, that we monitored. So it might be, but we only followed for a couple of years at that point in time. So, but we do not know exactly if this was a developmental regression. In some cases, we said yes, this is developmental regression, so we had to start treatment, and in some cases, we actually just got involved after somebody already regressed in one way. And so we say that I think we moved to a number around 50%. And that more of as a lifetime. So the 30 estimation I told earlier might be on the low side. I think it might be a bit higher. But how the most important thing is not just if it occurs, but just what do you do when it occurs. And I think in this case, in these cases, it's good to have an early detection, and a doctor who knows things about Kleefstra syndrome and how to work with this the regression. Yes.
Yeah. And I think it ties in as well to the importance of centers of excellence and the importance of the guidelines, which we talked about earlier today. So those guidelines are then, when they're out there in hand, so even people with their local doctor can say, there is a guideline that says what you should be considering if my child is showing up with regression. And I can tell you in the United States, one of the things that we do with our center of excellence is that we facilitate doctor-to-doctor communication. So if a doctor, let's say in California, has a patient undergoing regression, they could reach out to Dr. Sid at Boston and consult and say, look, this is my situation. What do you think what do you think expert to expert we should do? And I think that's another huge win for these centers of excellence, because they've seen a lot of patients and they have an idea of what you might consider at certain points. And so I think that's another thing to highlight for the community, is that there's help, and the COEs are there to help your doctor, not just you, but your doctor, if your doctor isn't sure what to do in a difficult situation, because this is a rare condition. And most doctors have only seen a few. The themselves. So
there is help,
yeah,
and there is a network, and
yeah,
the network strengthens all the time. So make use of that. Yeah.
absolutely. So we still have more questions. Obviously, regression is a very important topic.
Yeah.
So uh,
Understandably.
there's a yeah, and yeah, of course, for all the families, a very important topic. And if you have a family member, this is something that's always top of mind, I think. So a question came in of when you were doing your data collection, did you in some way segregate the patients in the way you collected data for verbal versus nonverbal, and how did you adjust for understanding their regressive state for patients that were verbal versus patients that weren't verbal? Maybe that goes to how you ultimately did your survey collection, data collection in the initial data, because you would have had to, I think the question comes down to how do you put someone on a scale when some people are verbal and some people are nonverbal? How do you figure out what regression means for different patients?
Yeah. That's you put them on their own scale. That's the main message in this one. So what you need to do in this case, and that's why close family members, caregivers are so important in this community. You need to know who this person with Kleefstra syndrome is, what their level of functioning is, what they can do, what they can't, what their abilities are, how they behave in daily life, what they do in certain situations. If you know somebody, you know by the tiny things that somebody is different, is behaving differently than they used to, and so you can compare a whole group. Of course, that's always possible, and but the thing is, you have this whole group of people who are verbal and who people are not verbal, and it sort of messes with your results. And we mainly wanted to see, and that's why we did the sequential design, so measurement after measurement, year after year after year, just to see on an individual level what happens. And if you look, and that's essential if you want to look into developmental regression, just knowing somebody and knowing when it's different, and that's the main part in this.
Yeah, and I think it speaks to the power of the approach of doing these prospective studies, because it's exactly what you're saying. Each patient is tracked as an individual over time. So it's for this patient, how did they do at year 1, year 2, year 3, year 4? And for another patient who may be much higher on the developmental scale, how did they do at each year? And so you're building up data instead of just throwing everybody into a pile. You can look at each individual person. Yeah. And I think that another point I think that came out, you had that graph. I wanted to highlight that graph that was all the lines all over the graph, right? And I think, yes, it's like, what is this? But it does make sense when you look at it carefully. But I think the other point that it makes is that KS as a condition has a huge, wide variability in terms of the severity of the effect, right? So there are people who are nonverbal and have trouble with mobility, and there are people who are verbal and can walk as well as you or you can walk, right? So we have to be very thoughtful about the way we design our studies, the way we design our interventions, and think about what is appropriate for each individual person. And I think that comes back to really good guidelines, working with your doctor, and reaching out to the Center of Excellence doctors when you feel like you need the help. And I think that's the value of what our whole community is doing together. I think that was all the questions.
Well,
So I have one more question, which is, do you have an estimate of when the paper will be released at this point? Do you have a guess as to when the paper is going to come out?
That's a good one. That's a good one. Well, the paper is a collaboration with Neil Nadif Kasri, and we're working together there's a more of a fundamental part of it, and there's a human part of it, and we're both busy with working on our several parts, and I think I'm hoping that it's difficult at the end, near the end of this year. I hope it will be published. Might be a bit sooner,
Okay.
might be a bit later, but somewhere near the end of this year.
Okay, great. Well, thanks again for all the work and for the work of the team and all the patients who showed up for the study. It was a lot of work for them too, I'm sure. So yeah, a um, huge step forward.
Thank
So
you
with
very much.
that, yeah, sorry, go ahead.
Yeah, of course. I want to take this opportunity just to thank you. Of course, we've talked a lot in the previous years. It's sort of a good warm welcome and a sort of a family reunion, so to speak, to be speaking at this summit. And I wish you all the best. And of course, thank you all for joining in.
Okay, we are actually, I can't believe it, we're ahead of time. This never happens at conferences. They're always running late. We're
I'm
ahead
so
of time.
sorry.
So we are going to take a break now in the conference, and we will return at 10 a.m. Pacific time, 1 p.m. Eastern time. And Jeff, did you want to make any comments since you are the master of ceremonies here?
No, all good. Thank you, Joost. Really, really powerful presentation again. I think regression is such a common topic, and so you can see it by the chat and all the questions. So thank you for hanging out and joining us again and answering all those questions. And obviously, there's a lot more work that we can do to try to curb the impact of this for families. So as we listen to the voice of the community and the voice of the patient, that's the one thing that we hear over and over and over again. And so it's our job to continue to make progress here. So thank you for your time.